One. I'm trying to get a little bit louder for the stream. hopefully they're in here in a minute. I'm hoping they come in a minute. Okay, no problem. We're ready to go.
So do you want to just announce that he's on his way?
I don't know. Yeah, somebody's asking me.
Hi. Dr. Lee is on his way, so just hang tight, please.
mind trying it out really quick just to see if we get the reverb? What we try to do, because it's for the video stream, because the students, a lot of times they come back and watch months later.
I don't know if I want to be recorded.
Oh, you don't want to?
So that works for sure, right?
It does.
Okay. Let me turn this on.
Oh, turn on right here.
I already
Oh, it's
did.
on right now for you. So if you just want to.
At one point, I need you to sign these two places.
Okay. Can I do it after the thing? Okay.
If you want to flip that to, I don't know if you want to test it out real quick.
Hello.
All right, I'm going to introduce our speaker today, which is Dr. Lee. He'll be speaking on the evaluation of syncope. Our program is underwritten by an educational grant through OSU Medical Center, which we have no money of. Graduate Medical Education. A disclosure statement has been signed as on file in the Graduate Medical Education Office. Dr. Lee has completed his medical school training at the Oklahoma State University. He completed his internal medicine residency at the University of Oklahoma College of Medicine in Tulsa, Oklahoma. And he is currently a third-year cardiology fellow here at OSU Medical Center. Let's welcome Dr. Lee.
Thank you, Dr. Comstock, for that welcome. So this topic, this is not just a cardiology topic, but seems to get a lot of cardiology consults. So, and rightfully so for some of the more malignant etiologies. So I was going to talk about this topic today, syncope. So first off, the definition of syncope is defined as a transient loss of consciousness, secondary to global hypoperfusion, and being transient, there should be overall a recovery without deficit. And why is this important? It's a little bit dated, but some of the studies that were done in the 80s to look at the prevalence and the cost of this problem saw these figures come out. Not a huge percentage per se of our hospital admissions and expenses, but still a significant portion. There are some guidelines in the Heart Rhythm Society and different societies to approach syncope and arrhythmias related to that. This is something from the University of Columbia, St. Luke's Hospital, that they had come up with some years ago to kind of try to simplify all that and to give you kind of a stepwise approach. First off, it's kind of hard to see, and it'll come out in other slides a little bit more, but components of this slide. But initially, it's always important to get a history, and that's what we emphasize to the medical students and residents, is a history of exactly what happened, how long it happened, and what different symptoms occurred during that time. And the physical exam, of course, and orthostatic blood pressures and EKGs are the initial evaluation that we would recommend, including labs. And they also had another acronym called SELF that kind of was used to define a true syncopal episode, and they would have to have all four characteristics of this. And SELF would stand for, the S would be kind of a short duration, E being rapid onset, L being a loss of consciousness but transient, and F being full recovery without deficits. And if they met that criteria, then you go down the stepwise algorithm and kind of proceed from there. And this is just what we just talked about. And if you go back and look from the Framingham study, which was a long study in terms of follow-up, here up to 25 years, one of the things that they noticed were the black line on the right side is the survival rate of people without syncope, so kind of the control group. The yellow line that kind of superimposed with that black line is people who did have syncope, but they were determined to be vasovagal or neurocardiogenic syncope, which had pretty much the same mortality as people without syncope. And the other causes, as you can see, the survival rate is on the y-axis. So the lower it is, the less likely they were to survive. And the one that is lowest is cardiac syncope, which is that pink line on the left. So based on all this stuff, it is important, if they do have a cardiac etiology, that we investigate that further. This is a breakdown of the different causes. As you can see, it's blocked off right now at the bottom right corner, but the unknown is about 39%. And then after that would be vasovagal. And those two in the previous graph, the unknown causes, which correlate with that, was the green line. So that was still worse in terms of survival, but that and the vasovagal were relatively, not as malignant as the other causes, the cardiac and neurologic causes. So, vasovagal plus unknown, approximately 60-ish%, relatively possibly low risk. And the other causes are kind of iatrogenic, possibly medication and whatnot. And the neurological stroke is 4%, cardiac's 9.5%. So those are the kind of considered the more worrisome ones. And as you can see, as a total percentage, they're not that high on the list. So in terms of a cardiac cause, you can break it down to structural, hemodynamic reasons. And these are a list of all those possible reasons. You've heard of some of these. Aortic valve stenosis being common in the elderly, especially. Hypertrophic cardiomyopathy, especially in young people. Whenever you hear anyone go that had syncope, that's a young adult, you always want to think about that. And any other structural reason that's listed above. The other thing, that was structural. The other thing that could also cause syncope, of course, is the electrical system. So any kind of arrhythmias, VTAC, VFib, obviously those are ones that we're particularly worried about. Even atrial fib, which usually is not necessarily a deadly arrhythmia, going fast enough for long enough to cause syncope. Wolff Parkinson White, of course, in the younger people, with the characteristic EKGs for that. Prolonged QT, which is really rare, but probably underdiagnosed, and then Brugada's. And then, of course, the Brady arrhythmia is listed there, the AV blocks and sinus Brady. And we shouldn't forget that there's also just the general vascular system. We don't necessarily associate it with these, but it is possible that pulmonary emboli could manifest as syncope, pulmonary hypertension even, of course, acute MI. And this is lower on the list, but aortic dissection actually can have syncope as one of the manifest symptoms. And so this brings us to the non-cardiac causes, which is also a pretty big list. The most common cause, which is up on top, the vasodepressor, vasovagal, neurocardiogenic, different names for the same thing, and then that can be broken down to different specific situational or other triggers that can cause that. Of note, that carotid sinus sensitivity, part of the exam that they recommend, that we do as a physical exam is actually carotid sinus massage to see if that elicits such a reaction. But before you do that, you have to be listen to their neck for a bruit, make sure there's no bruits, and also if they have any history of TIA or stroke, then do not do that, perform that maneuver. Of course, you also want to look at the labs, if they're anemic, volume depleted, and of course neurological reasons like seizures, stroke, and trauma. So in the younger patients, of course, the vasovagal, neurocardiogenic are by far more prevalent. And in the elderly patients, the arrhythmias and VTAC, a lot of times, because if they've had a history of MI or cardiomyopathy, and of course drugs. And we'll get to this, mention this later on too, but in the younger patients, interestingly, they had a consensus statement saying that trauma was the most common cause of death in males less than 40, but Brugada syndrome actually was number 2, so probably underdiagnosed. of course, with the long QT, sudden cardiac death, HOCM, Brugada's, they have some genetic components to them. So it's important to always ask if you see a young person if the family history of any kind of syncope or sudden cardiac death. Different parts of the history, like tongue biting, incontinence. Of course, those confusion, post-ictal states. You think about seizures or neurological primary causes. The other stuff, motion sickness, nausea, migraines, history in childhood, especially vasovagal. And of course, head turning, which would compress the carotids. That's also indicative of that. So there was this study that they looked at 80 patients, not a very big group, but just looking at the breakdown of the etiology of their syncope, a little bit less than half were vasovagal, and the rest were arrhythmia related. And of course, these people were about 58 years old. So, and then the spread from that plus or minus 17 years was a pretty big standard deviation there in age. And per this study, they had kind of narrowed it down to people who had the arrhythmia-related syncope had less, not very many episodes, more likely male, and they really didn't have much warning or any prodrome before the syncopal event, and they tended to be older. And of course, the other group had the vasovagal responses, as you know, the palpitations, diaphoresis, nausea, flushing, all commonly present before and a lot of times after the event. And as we mentioned earlier, initial evaluation, after you determine a true syncopal event, which you must get from the history, and not take someone else's report that someone passed out, and you talk to the patient, get the history, and then after that, look at the EKG for any sign of any arrhythmias. Of course, rule out orthostatic issues and the carotid sinus massage, which we mentioned, but of course contraindicated in those findings. Of course, an echo is a reasonable thing to obtain in true syncope if the other causes are not apparent. Further monitoring with like telemetry or with the Holter monitor or whatnot. Tilt table is also one of the options to assess for vasovagal syncope. And if there's any issue of cardiomyopathy or whatnot, stress test, echo, possible heart caths. And of course, the last line is just reiterating some of the other atypical presentations of other diseases, like aortic dissection, which can present with just that symptom at times. So the question is, how aggressively do you approach these patients? There's initially a thing that's called the San Francisco rule for high-risk patients, which is on the MedCalc, I believe, and the different calculators. But they kind of distilled down from their studies these 5 characteristics that, if any of these were positive, that would indicate this patient is high risk. And this had a sensitivity of about 96%. So if they had none of these things, you could feel pretty confident that they could pursue an outpatient evaluation, most likely, or no further workup. There's also later on a risk stratification study called the ROSE calculator. It's also investigated. This was done in the UK in one emergency room and then revalidated within the same center with new patients or successive patients. But they found that if you had any of these, which was known by the acronym of BRACES, this would indicate that they would be a high-risk patient and should be further evaluated by admission. Out of all these, they particularly noticed that the BNP was a independent indicator of possibly serious, etiology of syncope, but not only that, but also a prognostic indicator of just all-cause mortality. So the BNP level, for whatever reason, if elevated, is by itself, in and of itself, already a bad prognostic indicator. So And in that study, to make that calculator, their endpoints were serious outcomes, which were a list of 7 different things, but acute MI, was heart failure, PE, if they required surgery of a non-cardiac surgery even, or something very significant, or death after 1 month. And they found that using this calculator would be maybe even better, more potentially useful than the San Francisco, as it avoided approximately 150 admissions at the expense of missing 4 real cases, and no deaths for every 1,000 patients evaluated with this calculator. And so that could potentially save that many admissions, resulting in about $700 million in hospital stay annually. So roughly, both those scores or calculators could risk stratify successfully 90% of the time, or 90% of the people who probably would not need to pursue any further workup. So those are calculators you can use. But other high-risk criteria, kind of that's independent of those, but of course related in a lot of ways. Any kind of advanced arrhythmia, Trifascicular blocks, or advanced AP blocks, the 2nd degree, Mobitz type 2 or higher, sinus pauses greater than 3 seconds, and so on. Or structurally, if they have a cardiomyopathy, if their LE function is depressed, they're already high risk, depending upon how depressed it is. And of course, the channelopathies with the family history. So kind of started to talk about evaluation just briefly back there. Of course, but structural reasons, start with an echo, which is pretty reasonable. And then depending upon what we find or the further clinical situation, further workup with stress test or cath. And normally, if there's an arrhythmia that's noted, there are criteria to consider an EP study that may result in a intracardiac device also. So the indications for an EP study, class 1, if they have LV dysfunction or cardiomyopathy, prior MI. This is all in the study of syncope. This is not just you take all people who had MIs and do EP studies. But if they had syncope and they had these other conditions, they used to do more EP studies with people who had MIs and low EFs to induce arrhythmias like VTAC and VFib. But they've kind of gone away from that because now we have class 1 recommendations saying, if they have an EF less than 35%, that has not improved despite medical management or vascularization with stents or CABG, and they're already indicated for a primary prevention device. Class 2, if they have a widened QRS or existing bundle branch blocks, if they have palpitations, and if they have any of the channelopathies and the inherited arrhythmias. The last one, select patients in high-risk occupations. The one that comes to mind probably the most is airplane pilots. If there's any question of syncope or any occurrence of syncope in these patients in these kind of jobs, they have a very low threshold to prevent them from working. So even truck drivers that have ICDs, and we see in the office, and they cannot go back to work with that in there. Of course, class 3 means contraindicated. They have nothing of note, then shouldn't be doing anything additional. So here's an example of some of the arrhythmias in terms of the syncope that we see occasionally. This is a Brugadas, and their characteristic thing is V1 through V3 are the leads you look at, and that kind of coved upward ST segment, then downward T wave. That's kind of characteristic. There's 3 types, and that's type 1. And you have to have it in at least 2 leads or more T3. The other types, the type 2 is a saddleback, same place, but instead of the cove top, it would just be inverted into kind of like a downward depression. And then type 3, just a mix between those two. And if you just see the EKG sign on there, that's concerning to note, but if they don't have any syncope or any other issues, then you really can't call it Brugada syndrome. But you probably would need to follow up with them and watch them, because if any kind of triggers, like caffeine, drugs, anything can sometimes trigger them to be more prone to having an event, though, with that kind of finding. So the mean age of death is about 40s. And the consensus statement in 2005, which was kind of a second consensus statement, they had announced that Brugada syndrome was that prominent in what they found in terms of the cause of death in young males. Of course, the highest incidence was found in Southeast Asia and a little bit in Europe. What they were referring to as sudden unexplained death syndrome. Sudden unexplained nocturnal death syndrome, which is that word's blocked off from that PNP or PIP. And then this is an example of long QT syndrome in EKG. And just remember that the QT interval you measure from the onset of the QRS, which is right around there, to where the T wave ends. And if, Dr. Brewer would tell us the poor man's way of doing it is if the QT segment was greater than half of the Q to Q interval, that would be prolonged QT. So, and on the EKGs, when you see the computer spit it out, the QT intervals, look at the corrected QT interval, because that corrects for the heart rate, which is important. But if the QTC on the EKG is long, always verify that visually, because sometimes the computer will think that the segment is longer or shorter than it really is. So, because this QT syndrome is still pretty rare. So, and of course, the easiest thing, which I've done too on consults at St. Francis, even or whatnot, is just repeat an EKG and it's normal, the QT interval. So. Another thing that could cause syncope, a trifascicular block. It's a little confusing, I think, this terminology, because let's go to the next one. Because there's actually 3 fascicles. You get the AV node, there's the His bundle, and that splits off into the right bundle, which is a solitary bundle that goes to the right side. And then the left bundle kind of splits off into left anterior fascicular bundle and the left posterior fascicular bundle. So that's 3. Those are the 3 fascicles. And I guess it would make more sense if I also said that trifascicular blocks could be considered incomplete and a complete. And a complete would be all 3 of these were blocked, which would lead you to third-degree block. But usually what we see is most common scenario is going to be a bifascicular block involving the right bundle almost always with the left anterior fascicular block, and then having an AV block higher up, first or second degree. Interestingly, this is kind of concerning when you see this on the EKG, but unless they're having symptoms, the progression of this to a complete heart block is pretty rare, like about 1% a year. So it's important to note, but they don't always progress. Of course, a complete would be bifascicular block with a third-degree AV block at the AV node, which would be an indication for a permanent pacemaker. So, as you can see here, there's a right bundle branch block, and then left anterior fascicular on this. Look at the axis, and it's left axis deviated. And then, if you can see that this is the P wave, so the P to the QRS, that is certainly prolonged, as the normal is 0.2. So this is just another example of a trifascicular block. Sorry, not trifascicular block. I'm sorry, that was a Wolff-Parkinson. And Wolf Parkinson White being another arrhythmia that we were concerned about, mostly in young people. You kind of see that characteristic delta wave, which is kind of makes the PR interval shorter, indicating pre-excitation. And there's two types, type A and type B. Type A has the tall R waves in V1, indicating most likely a left-sided accessory pathway, and type 2 would be prominent S waves, indicating right-sided accessory pathway. And the reason that this is important is this is the normal right atrium, left atrium, and conducted from the SA node, goes down to the AV node, which is here, and we conduct to the ventricles normally. And this accessory pathway usually is, if that's conducting on its own, it can accelerate and cause a tachyarrhythmia, and causing potentially VTach or VFib, causing syncope. So, of course, it was first discovered in 1930 by these three gentlemen. So a lot of times on EKG, which is part of the initial evaluation, you don't always see an abnormality because usually they're not having symptoms, so you'd have to consider further monitoring. Of course, we know the 24-hour, 48-hour Holters, which, unless they're having symptoms multiple times a day, are pretty low yield. And then the loop recorders are 30 days, which increases your yield, usually, if they're frequent enough, but that depends on the patient activating the recording session. When symptoms occur. And then, of course, there's implantable recorders also. And tilt table testing, which we'll get to. So the ambulatory monitoring actually basically is going to be like just mobile telemetry for the most part, except for the event monitor. But depending upon the time frame, would direct which one you choose. Elderly patients, or if they have really rare frequency of events. I think there was a guy that had an event once a year, and they put an implantable recorder in him, and they actually caught him in VTach when he passed out. If something is really prolonged in terms of frequency, then implantable loop recorder is a very good consideration. So once again, the Holters will record for 24, 40 hours just nonstop, just like being on telemetry. Better for people who are having frequent symptoms. The event monitors, they have to activate them, but they can go for about 30 days. And they have wireless versions of both of these now. One of them is CardioNet, which is basically a wireless Holter monitor that goes for longer than 24 hours. Usually you want to use these for people who you suspect a possible arrhythmia, but they don't have any high-risk features, which we talked about before. This is just another company similar to CardioNet. The main difference was they pointed out that they can set up so that EMS can be activated automatically, or they can contact them if they see something. CardioNet just pages the physician, which I guess who then decides how to proceed. The implantable monitors are the ones that you might have heard of that just go underneath the skin. A small nick is made in the left sternal border, and the nick is about 1 or 2 centimeters, and the loop recorder is on this kind of device where you place it on there into the hole, and it just literally inject the device in there, and that's it. And some of these Medicare, the guidelines for the implantable monitors, actually there's not very clear guidelines in terms of the American Heart Society or Cardiology Society, but the Medicare has some of their guidelines, which are listed right there. They kind of had a negative evaluation in general, and something to consider. Of course, recurrent episodes. And these are the supposed to be Reveal and Sleuth. Reveal is the Medtronic one. lasts up to 3 years. And right now they're being put in cath lab, but eventually they should be able to put in the outpatient setting. And the European Society of Cardiology does have their recommendations for these implantable loop recorders, and their recommendations, though, are similar with recurrent episodes without any high-risk features, of course. If they're high-risk patients, but they've already undergone a workup and they haven't found a cause, those are Class 1 indications. Class 2A, if people, if they do have vasovagal syncope, they're known to have that, and there's concern about their bradycardia being symptomatic and that they would require a pacemaker. That would be another reason to put a loop recorder in them. And of course, the last one is just about duration of symptoms. So if they're less than or equal to 4 weeks, the loop recorder would be reasonable. And there's a study done in 2003 that kind of just compared people who went through a typical workup with tilt table, EP study, versus just a loop recorder. And they found, the difference was that the implantable loop recorder cost about $5,000 or $6,000, but the other workups, ended up being more expensive at $8,000. So they seem to be more cost effective there. There's also this picture registry, which is a prospective multi-center study that followed about 600 patients with recurrent syncope who received the loop recorder, implantable loop recorder, and they compared the people that the workups that they underwent, and on average they saw three different specialists. So some saw more, some saw less, and they all underwent at least 13 tests, anywhere up to 20 different tests. And the implantable loop recorder was able to provide diagnosis in 78% of patients just on its own. So compared to the other workups that they didn't yield much. So another study to support the use of those. And of course, other things that you would, palpitations, even if they didn't have syncope, they're exploring possibly using these for risk stratification for a post-MI and also for people who may or may not have AFib. The one on the right is the one that goes under the skin. It just injects. And the tilt table testing, which you probably have heard of but may not be familiar with, this is specifically to test for kind of neurocardiogenic autonomic system pathology and people who have the symptoms of vasovagal syncope. If you want to provide some objective evidence that proves that, this is what you would go to. And there's some explanations about vasovagal syncope and how it works. But it's divided into two etiologies: the cardioinhibitory, which is more bradycardic, and then the vasodepressor, which is more the hypotension. And most people can probably have both, and not just one solely. And there's, of course, a reflex, a basilar-Girish reflex, which is thought to be partly responsible for this. The tilt table testing starts off with a passive, meaning that there's a protocol where they were brought from a supine position to an upright tilt, anywhere from 68 degrees for a certain amount of time, 45 minutes. Their vitals are monitored at a fairly frequent rate, and any change in their heart rate and blood pressure is noted, and their baselines are defined by their initial 10, 15-minute readings. Tilt table looks like. And of course, if they're positive from the stage 1 test, which the criteria for that will be the next slide. If they're positive, though, then they do not need to proceed further, and they don't have to necessarily have syncope provoked, but symptoms are enough. We can also do the chemical version and try to provoke the same effects. And so the positive response would be defined as a 25 millimeter drop in systolic blood pressure, which is sustained for at least a minute. And it's not accompanied by an expected increase in heart rate. And one of the other things that can come out of this testing, other than vasovagal syncope, but kind of related, is postural tachycardic, orthostatic tachycardic syndrome, which is kind of this paradoxical where people will stand up and their heart rate will increase significantly, and they'll feel symptoms of pre-syncope or syncope. The vasovagal syncope is actually subdivided into three types, and type 2 is subdivided into two. But type 1 is the mixed one that we commonly see, and that has all this criteria where the heart rate decreases with syncope, or may decrease with or without a pause, and blood pressure usually decreases prior to the heart rate decreasing. Type 2A and type 2B are just kind of cardio inhibition, so mostly dealing with heart rate and whether there's the presence or not of asystole. And type 3 is just a pure hypotensive response. And in preparation for these tests, tilt table, it's kind of like any other test. A lot of tests, have them fasting for so many hours before. Of course, try to discontinue any kind of drugs. Of course, beta blockers, any kind of cardiac drugs, or any other kind of drugs they might be on for, some of the medicines like bladder, incontinence, and whatnot. But these tilt table tests, they're not. Different studies give different answers in terms of sensitivity and specificity, and as you can see, the range is pretty big. So, if you do get a result, it can be helpful. If you don't, though, it doesn't mean that they don't have this diagnosis. And there's some other drugs you can try to use.
That's why we get a microphone.
Well, hopefully they'll make most of it out. Okay. Yeah, you don't take this, right?
Yeah, we can leave it here. She'll come and grab it, I think. That's what and I can get your PowerPoint for you if you want.
Oh,
If you want your...
I already pulled it out.
Oh, you did? Okay.
Yeah.
Perfect.
I know they say you're supposed to eject it, but I've never seen adverse effects.
I haven't either.
It's almost like the disclaimer that comes on your car or something.
Uh-huh.
You're gonna use that, the camera.